So this is the outline of the chapter. We'll start first with the perspectives on schizophrenia, and then we'll try and understand further its clinical description, symptoms and subtypes, as well as the prevalence and causes of schizophrenia, and later on the treatment. Okay, now for the questions, these are the focus questions that we're going to try and answer. First up, how is schizophrenia defined? And what are the clinical features of schizophrenia? Also, we'll try to answer the features of the other related disorders. And then we'll also try and understand and go through it one by one. What are the positive, the negative, and the disorganized symptoms? Now, this one is very important to understand, especially when we try to see what schizophrenia is all about. And then, what are the factors that have contributed or contributes to the development of schizophrenia in a person? And then lastly, what treatment exists for the condition of schizophrenia? Okay, so when we talk about schizophrenia, this is defined by a broad spectrum of cognitive, okay? Let's try and highlight this one. Cognitive and emotional dysfunctions, okay, which includes delusions, hallucinations, disorganized speech and behavior, as well as inappropriate emotions. So this is why when we say that someone has schizophrenia, the functioning, cognitive functioning and emotional functioning are both affected. Because on the cognition side, they are having delusions, these beliefs that are not really real, and then hallucinations, sensory experience that are not really there. And then aside from that, part of the cognitive function is or are allowing us to have speech and behavior, but with these people or people with this condition, they do not have the normal speech and normal behavior because of the problem in their cognitive functioning. And then, of course, on the emotional side, um, we are talking about the affect that is not supposed to be there, or the affect that is um, incongruent with the situation. Okay, now to have a backgrounder about the condition, um, it was first termed first as dementia precox by Emil Kraepelin, who was the first to notice or observe these symptoms, or this group of symptoms with his patients. And the early subtypes of schizophrenia, rather, were enumerated as such: the catatonia, hebephrenia, and paranoia. Now, this one is already an obsolete term. There's no more. We don't call it hebephrenia anymore. Um, although we see catatonia and paranoia as part of the subgroup of symptoms for the schizophrenia. Okay. And then we also have Eugene Brewer, who have introduced the term schizophrenia, wherein basically it literally means splitting of the mind. And along with that term, he also identified different variants that were all included in the spectrum of this particular condition. Okay, so what's the nature of schizophrenia and psychosis? The many of the ideas of Kraplin and Blower are still with us. So um, the way they thought about schizophrenia are still the way that we think about schizophrenia. I know that there's not a lot of progress yet, but with the constant evolution of the symptoms, I think that's progress enough. And the things that we understand better with how the brain works, that's I think where the progress is happening. So with schizophrenia, understanding the onset of the behavior, when did it first start manifesting, and the course of the symptoms are considered to be very essential in this particular condition. This is because when we understand when it happened, it can lead us to better analysis of the the condition, and also what's really happening in terms of the experience of the symptoms. And when it comes to the course itself, we are able to see the severity when we know the course or the path that it's taking. It's not enough that we have identified the symptoms per se, but it's really essential that we both see the onset and the course. When we talk about psychotic behavior, we are basically in clinical language or in the clinical parlance, we're talking about the difficulty, not the difficulty per se, but rather the experience of hallucinations and delusions by the person. Okay, so once they have hallucinations, that is already considered as a psychotic behavior. Once they have or exhibit delusions, that's already considered a psychotic behavior. Or at times this one, but at times this part, the unusual behavior part, might be mistaken for another symptom of another condition. So this is why it's really important that you know which is which in order for you to be accurate in your diagnosis. Okay, now with the symptoms of schizophrenia, this is where it gets a bit confusing. So when we say positive symptoms, these are the know-how here in the field of normal psychology. So when we say positive symptoms, these are the delusions and hallucinations. And this is called positive symptoms because these are symptoms that they have when they shouldn't have it. Okay, so I hope you're getting it. Again, it's called positive delusions because they have it, but they shouldn't have it. Okay? Next would be the negative symptoms. So the negative symptoms are the following. So we have the avolition, which is the ability to initiate and persist in activity. So it might be doing their work, it might be chores, it might be simple tasks, um, so on and so forth. We also have the alogia, wherein there is an absence of speech. So it's either they are not really talking, or what they're saying doesn't really make sense or anything. They also would have, or they can have anhedonia, or the presumed lack of pleasure. They don't experience pleasure anymore, even with the things that they used to enjoy. Like for example, um, they uh, they they get happy when going out. However, you would see that they are not really that enjoying themselves when you go out. Asociality, so this is why I mentioned last meeting, the term is not antisocial but asocial. When we say asociality, there is a lack of interest in social interactions. So when the person does not want to associate or connect with people or talk with people, especially with their friends, their family members, that would be put under this particular condition or symptom. And then we also have the last one, the affective flattening. The affective flattening is when the person does not show any emotions, when usually you would expect them to show emotions given the situation or the circumstances. So, like for example, you're watching a funny show, all of you are laughing, but this person is not cracking even a smile at the joke, okay? So, these are all the A's of the negative symptoms. So, abolition, alogia, anhedonia, asociality, and affective flattening. So, these are 5 A's. So, now, why do we call it negative symptoms? We call this negative symptoms because these are the symptoms that they should have, but they don't have it. Alright? So, again, positive symptoms are the symptoms that they have, but they shouldn't have it. And then negative symptoms, the 5 A's, are the symptoms that they should have, but they don't have it. Alright? So this is a minus for them because they are expected to have it, so minus, but they don't have it. This one is a plus for them because it's something that we're not expected to have, but they have it. So it's a plus for them. Hence the positive and negative symptoms. Okay, so it takes a while to fully master it, but once you get the grasp of the concept, you're going to understand it easier. And then the third type of symptoms for schizophrenia are the disorganized symptoms. Now, the disorganized symptoms, from the term itself, there is a lack of organization in symptoms. Like, for example, with their speech, their pattern of speech is very erratic, that they don't sometimes make sense anymore. So that's why it's disorganized. And then the emotions are also all over the place, so hence disorganized. And then we also have the inappropriate affect. So again, just like with the other conditions before, there are, like for example, the situation is very sad yet the person is laughing, that is inappropriate affect. Or disorganized behavior, like for example, they with their hygiene, they are expected to take a bath every day, but they are not really taking a bath anymore. Or it's already night and they are supposed to go to sleep, but you see that they are not really getting enough sleep, or they are not sleeping anymore. Okay, so breaking down further the symptoms of schizophrenia, let's see first the positive symptom cluster. Now, the positive symptom cluster, again, it includes the delusions and hallucinations. Now, when we say delusions, we are basically saying this is the basic feature of madness. So, you're crazy already if you have delusions. To put it simply, we have delusions as a gross misrepresentation of reality. And with that, the most common is the delusions of grandeur. I'm the Queen of um, uh, I'm the Lakan of this Malaya Republic. So that's delusions of grandeur. Because first and foremost, um, you believe that you are special in this world that doesn't exist, or in this place that doesn't exist. And then, of course, to say that you are the Queen of England when you're not even English yourself, that's very delusional, so to speak. There are also examples of delusions of grandeur, like claiming to be uh, part of uh, the line of Jesus Christ. Those are delusions of grandeur. Um, or saying that you are a genius. People just don't recognize it even when your IQ results show that you are on the average level of intellectual functioning. Then we also have delusions of persecution. Delusions of persecution, this is what we usually see with people that has a paranoia. They they tend to believe that people are out to get them. So this is why I mentioned last meeting that looking or watching A Beautiful Mind, this will give you a better idea of understanding what schizophrenia is. Um, he had John Nash, the character, or the person in the movie, had delusions of grandeur when he was alive. And in the latter part of his condition, he was saying that the FBI is out to get him because of the top secret project he's making for them. When in reality, so actually he both has delusions of grandeur as well as delusions of persecution. In actuality, he is not contacted by the FBI. Okay. So that's it for the delusions. Let's move on to the hallucinations. Now, hallucinations, these are the experience of sensory events without the environmental input. So, in your lower level psychology subjects will learn that when um, we learn that we experience things because of our senses, right? So you're able to hear what I'm saying, you're able to read what I'm presenting here because of the sensory input um, by your visual. Uh, uh, yeah, visual organs and auditory organs, or your eyes and ears. However, for people who has schizophrenia or who have schizophrenia, they tend to have hallucinations wherein they experience sensory events without the environmental input. So meaning to say they are seeing things and hearing things even when it's not there. So, and then with their hallucinations, it can involve all of the senses, all five senses. We're talking about this one. However, the most common hallucination is the auditory hallucination for the patients with schizophrenia. There are, of course, tactile hallucination, olfactory hallucinations, smelling things that are not really there. Um, however, these things or these types of hallucinations are quite rare. So the most common is auditory, and second to it is the visual hallucination. Okay. Now, what they have found out in the brain studies or the neuroimaging is that um, for patients with auditory hallucinations, the broca's area or that part of the brain is the one that's lighting up or the one that is active um, when when they are having these hallucinations. And what is the Broca's area? Remember the Broca's area, this is part or this part of the brain is the one that allows us to produce speech, and it's not there or it's not the one responsible for the comprehension of the words that we are hearing. So what does this tell us? Basically, the idea of this study is that the hallucinations may be of less of an experience of hearing things that aren't there, but this is more of an experience of listening to one's own thoughts or self-generated voices. However, the person is not really able to tell the difference between these voices and the external auditory input. So basically what this tells us is that they might be hearing their own selves talking, or they might be hearing their own self-thoughts, or they are basically generating these thoughts because again, this is part or this is the part of the brain that produces speech and not really the one that understands the speech per se. So it's the one that's producing it. So if if it's really someone else um, producing it, then definitely the one that should light up should be this area, the vernix area, wherein this is the part of the brain that is processing the thing that we're hearing. Okay? However, in auditory hallucination, the part of the brain that is implicated is the Broca's area. Okay, now breaking down the negative symptom cluster. So in the negative symptom cluster, there is an absence or insufficiency of a negative behavior. Sorry. So normal behavior. So again, this is why it's a minus for them, hence negative. Okay? So these are all spectrum of negative symptoms. So first of is the abomination, wherein um, or apathy. Some books call it apathy, wherein they don't really initiate things, or they would lack persistence in doing things. Like for example, they are working and then they just start working and then suddenly stop because they don't want to. They don't have the drive to work anymore. And then we have again the logia. This is the relative absence of speech, and hedonia, lack of pleasure or indifference, and affective flattening, wherein we see that there is little emotion expressed. Okay, now for the disorganized symptom cluster, again, there is confusion or abnormality in speech, behavior, and emotion. So confused, again, speech is more on you don't really understand the context of what they're saying. Abnormal speech would be they are saying words that are not really words. They are jumbling their words, or they are making up terms that are not really in the dictionary. And then of course behavior wherein you would see them doing things that are not within the norms of the society, or they have this confused behavior, like for example they would say, I have to get home because I have kids waiting for me, but the person does not have any children. So that's a confused behavior. And then of course emotions, the emotion is not congruent to the situation wherein if the situation is supposed to be funny, the person is not laughing or showing the slightest emotion that is related to uh, fun or finding it funny. And then with the disorganized speech, we have what we call the cognitive slippage, yeah, where there's illogical and incoherent speech, tangentiality, going off a tangent, like for example, oh, I went to the doctor today and then I got oranges from the market. It tastes like the river Thames. So, so it started first with going to um, the doctor, and then he was going off tangent with different other things. And then loose associations. So it might be confusing for you because some of them are like that. The loose associations can be like tangentiality. Um, you really have to practice to see which is which of the two. With loose associations, they would connect things that are now really connected. Um, like for example, they would say, I woke up today and I brushed my teeth, and then I went to the market and then I saw you. So they were basically telling you things, but it's a bit confusing because they're jumping from one idea to another. Okay. Okay, so for the nature of disorganized affect, so this is wherein there is an inappropriate emotional behavior. Like for example, when they are mad, they they I saw a patient once who was mad but she was laughing. Usually when we're mad, we raise our voice, we tend to get aggressive, but she was really laughing while telling us that she was mad. And then with the nature of disorganized behavior, there is a variety of unusual behaviors. We had um, one neighbor whom we he was not really diagnosed. He was just the neighborhood. He's a neighborhood character who's been around us since for as long as I can remember. And then I would usually find him when I was a student. I would usually find him going around the neighborhood and picking up trash. And then when I would say, um, Polly, what are you doing? And he was, no, I'm just picking this up. I might use it later on. So that those are unusual behavior because basically it's really picking up trash. he's picking up garbage, but he was saying that he can use it later on. And then some of the trash, he said that he can eat those trash. So those are some of the unusual behaviors that I've seen. So this is why I suspected him to be schizophrenic. However, when I asked around, it turns out that his relatives didn't really have the money to have him checked up, so they didn't have a proper diagnosis of his case. And then another type or the disorganized behavior can be manifested through catatonia. Now, catatonia, it before DSM-5, we have a subtype of schizophrenia um, as catatonia. So schizophrenia, catatonic subtype, wherein this is something that occurs with the other symptoms of schizophrenia. But in the DSM-5, it's already part of the symptom. It's not a subtype anymore. So, actually, it takes uh, a little bit of getting used to. Okay. So, schizophrenia, as I was saying earlier, schizophrenia used to be divided into subtypes based on the content of the psychosis. So, if the client has um, delusions of persecution and hallucinations are persecutory, like for example, people are going to kill me, people have bad intentions about me or to me, we would classify the person to have paranoid schizophrenia. So that's one of the subtypes of schizophrenia before. However, we don't do that anymore. And although these terms, like for example with catatonia, we still use it in the DSM-5, but we only use it partially. So, uh, among the inclusions are the terms paranoid, catatonic, residual, wherein there is the minor symptoms that persists after past episodes, disorganized, wherein most of the symptoms are mostly disorganized symptoms and not the other symptoms, and of course the undifferentiated. Okay, now why were the subtypes removed? Now, to answer that question, the subtypes were removed or were eliminated based on the limited diagnostic stability, reliability, and validity. Aside from that, what they have seen, or the professionals or uh, the specialists in the field have seen, is that the subtype similarity in course and treatment um, response are pretty much the same. So it does not make sense if we have different, or we cluster them in different groups, um, thereby making things more complicated than it is. So they felt that making or eliminating the subtypes will make the this particular condition easier to understand and easier to assess. Okay, so what are the other psychotic disorders? So we have first the schizophreniform disorder, wherein the psychotic symptoms lasts between 1 month to 6 months. So greater than 6 months, it's already considered as schizophrenia. However, if it's just between this particular period, it's still this disorder. And usually, people with this type of condition has relatively good functioning as compared with the person with schizophrenia. And most patients would resume normal lives. And the lifetime prevalence of the condition is approximately at 0.02. I think the neighbor that I've been telling you about earlier would fall under this category, the schizophrenic form. However, in terms of the duration or the course, um, he wouldn't fit that. So that's why I said that is more schizophrenic. But in terms of functioning, he functions really well. Um, if we ask him to do things, because he used to volunteer in the church, so we would ask him to do small errands, um, and he was able to do that, and he did it very well. Um, Unfortunately, this one, this is why he does not fit this particular cluster. Next, next would be the schizoaffective disorder. Now, the schizoaffective disorder are combination of the symptoms of schizophrenia plus an additional experience of a major mood episode. So it can be either a depressive or manic episode. And then the psychotic symptoms that they would experience, the hallucinations, the delusions that they would also experience, must occur outside the mood disturbance. It means that um, these two, although these are combined symptoms, they don't overlap with each other, they don't happen together. Okay. So usually prognosis is similar for people with schizophrenia. Meaning to say it's guarded because of the fact there is another element here of the mood condition or the major mood episode. And since the prognosis is guarded, um, people with this condition would need a lot of help from the people around them. So it's both psychotherapy, psychopharmacology, and of course, um, strong social support. Is the delusional disorder, wherein the key feature of the disorder is just having the delusions. So they don't have the other positive or the negative symptom, meaning to say they don't really have hallucinations, and they don't have the negative symptoms, so to speak. And delusions tend to be um, either delusions of um, grandeur, persecutory, so those are the common delusions, but we also have other type. The other type is the erotomanic delusion, wherein um, you have this conviction that someone else is in love or attracted to you. Often you would say that um, this person like a person who holds a high position in the government, or a person like in the drama, the CEO of the company, even though the CEO does not know you, or you would say, oh, the CEO is in love with me. Or I would say, Jungkook is in love with me, and not the other way around. So if that's my claim, that I would, or you can say that I'm having an erotomanic delusion. Um, and then we also have the somatic delusion, wherein it is the one that, like for example, the belief that you have to walk carefully because your bones are made out of glass, so those things. There are cases like that. I have not experienced or I have not encountered a case like that. I did, though, read something to that effect. And then, of course, the jealous delusion wherein you feel that the partner um, has other involved with another affair, despite of the lack of evidence or the reality that there's really none. Usually, with this condition, since they don't have the symptoms, the other symptoms that make up for the psychosis, they have actually a better prognosis than schizophrenia. So the prevalence of delusional disorder actually is very rare. So according to the statistics, it only affects about 26 to 60 individuals for every 100,000 individuals. And usually this happens in the later age, between the ages of 35 to 55. So when I start sprouting nonsense like Jungkook is in love with me, you might say again that Mom Karen is having a delusional disorder, the erotomanic type. And the statistics have shown that this is more common with females than males. And in actuality, there are about 55% of patients with this disorder who are female. Okay, so another type or within the spectrum of schizophrenia is catatonia. Now, catatonia is unusual motor responses, particularly the immobility. Means to say the person is not moving, or agitation, very restless body movement, or odd mannerisms. The might be the body is contorted in very unusual positions. And having catatonia is severe, but it's quite rare actually. This may be present in the psychotic disorders or this can be diagnosed alone. Um, so this may include the following. So the first one is stupor, mutism, or maintaining the same pose for hours. Like for example, if you would imagine a mannequin, but only the mannequin is a real person, and you're going to put the mannequin in a position like bending forward with the arms raised above, one above his head, and the other arm is in front of the head. So you can just imagine how uncomfortable it would be if you are doing that kind of pose for several minutes, how much more for several hours. But patients with catatonia are able to hold that position for hours actually. Or sometimes they have this opposition or lack of response to instructions. Like for example, if you tell them to raise your hand above your head, they wouldn't be able to do that. Or they also have this one, repetitive or meaningless motor movements. Like for example, this can be confused for a tic. Like for example, their shoulders keep on getting up, or they keep shrugging their shoulders. So those are repetitive meaningless motor movements. Or sometimes they would mimic another person's speech or movement. So it's not that they are doing that intentionally. It's just that it's the symptom. It's the symptom of their condition. Okay. So, what are the other psychotic disorders due to other causes? So, psychosis actually can occur as a result of substance abuse. So, this is why um, we don't do drugs, right? Okay. So, and a substance, okay. Substance actually, the prolonged use of substance, um, they have a higher possibility of having psychosis or psychotic disorder later on in their life. So, we have also a neighbor like that. Um, it's a different neighbor. Had been a, he had been a drug user for several years, for as long as I can remember. He is the older brother of one of my schoolmates, and I think even when I was younger, he was already using drugs. When I was in elementary, he was already using drugs. Um, and then he went through the rehabilitation facility for several times. However, the treatment or the intervention was quite ineffective because every time that he gets out of the facility, he goes back to the drug use. And then I think when I was in graduate school, he started manifesting the symptoms. I overheard some neighbors saying that he was telling them that he was seeing things, he was hearing things, and there was a point that he was roaming around the neighborhood at night because he thought he was part of the, I'm not sure if it's the barangay tanod or if it's the police, but he felt that he was there to guard the neighborhood because he was in the position to do that. So he was already having delusion. There are also some medications that can cause a psychosis. Um, but unlike with the drug use, it's not that prevalent, and because the medications are prescribed medications, so the doctor will be able to see if there are some of adverse side effects or side effects that we don't want. Okay, so knowing the cause of the psychosis are very important for the treatment, of course. Like for example, if the medication that you're taking is the one that's causing the psychosis, then the most basic treatment would be taking you off that medication and looking for an alternative medication in order to cease the psychotic symptoms from happening. So included under this condition or this cluster are the substance or medication-induced psychotic behavior, and the other one, the psychotic disorder associated with another medical condition. Okay. Then moving along, we have the brief psychotic disorder wherein the person would experience positive symptoms of schizophrenia, either hallucination or delusion, or the disorganized symptoms, but the symptoms would be for less than 1 month. So this condition has the briefest duration of all the psychotic disorders, and usually this is triggered by a trauma or a stress. Um, so this is why when caught early, this can be easy to manage or to treat. And then we also have the uh, so the actually let's just skip this one. This one is in DSM-5. It's supposed to be a condition for further study, but in the DSM-5 DR, um, it's not in the chapter for the schizophrenia spectrum disorder. Okay, so the onset and prevalence of schizophrenia worldwide. So the latest is that about 1% of the population has schizophrenia. So you can just imagine the number um, with given the population of the Earth at present. So we are at 8 billion. So what's the 1% of that population? So it's quite a big number. And often it is seen to develop in early adulthood, although there are cases wherein um, children manifest schizophrenic symptoms. So I'm not sure what's happening with them. But as was said here, childhood cases are extremely rare but are not unheard of. So I'm not sure if it's online, but I think I have seen an episode of Oprah wherein their toddler um, has been diagnosed with schizophrenia. Um, the doctor was saying that the child's play, the supposedly imaginary play of the child was not an imaginary play because basically the child was having hallucinations and yeah, the hallucinations uh, with uh, with the with his case. So it's quite a heartbreaking story. Okay, so for the course of the disorder, usually schizophrenia are generally chronic, and most suffer from moderate to severe lifetime impairment. So this is why I always tell my clients to always check up, have the follow up or have the routine check up, whether psychiatrist, because the symptoms can be managed better with the prescriptions. The life expectancy is less than average usually because of the increased risk for suicide, especially if it's schizoaffective disorder. There are also increased risks for accidents because of the hallucinations that they would be having. And then, of course, self care might be poorer. So, therefore, aside from their hygiene, um, they might be forgetting to eat, or if they are eating, are they eating properly? So that would be the important question there. Okay, with regards to the gender and culture, um, the number of people being affected by schizophrenia is about equal for the gender, for male and female. However, females tend to have a better long-term prognosis given the fact that um, they socialize better. Um, because again, remember that part of the intervention is a strong social support. And then for the onset, usually schizophrenia happens earlier for males than females. Um, Cultural factors, the psychotic behaviors are not always pathologized, meaning to say it's not considered as a symptom for some culture, like for example, for a very religious culture, um, like the Indian culture. Um, I forgot I think I saw it on Netflix. It's if I'm not mistaken, the title is House of Secrets. And one person led everyone inside the home. Remember, in the Indian culture also being an Asian culture also lives with the extended family. So there's one family member that led the rest of the family member to commit suicide. And this is because they thought that his hallucinations was really the late patriarch or the father or the grandfather, the father of that person who was speaking to that person. So I hope you are aware of that documentary. It's quite a good documentary to watch. This is how we can see the effects of this um, beliefs to the mental health of people, because he was supposedly traumatized by um, at, he was traumatized by an experience. He was intentionally locked in a burning warehouse, but he was able to escape. However, he manifested signs of PTSD. However, his family did not want him to see the psychiatrist. They don't want that because they were saying that no one in the family is crazy. But then later on, he developed this belief that his father is speaking through him. And then slowly, when their um, life got better, their business actually boomed. They thought that, oh, really, the father in this family is really speaking to him. So they had that belief. So uh, they didn't really had him treatment, have had him treated for his PTSD. And then later on, he led the rest of the family members, even the youngest family members, to commit suicide because he made them all believe that they will be going to they will be serving a higher purpose and going to the nirvana of sorts. So so they have what we call a shared delusion. Okay, so although this is the case that there are some culture that does not pathologize some of the symptoms or some of the psychotic behaviors, um, the rates of schizophrenia is found to be similar across culture. Okay. Okay, so how about, or how does the course of schizophrenia go? So we have the prodromal phase, which is about 85% of the experience. This is about 1 to 2 years before the serious symptoms happen. Um, people with this condition or people in this phase usually have severe but unusual symptoms like ideas of reference, like the one with the schizotypal personality disorder, magical thinking. So this is why people who are diagnosed with schizotypal PD have a high tendency to develop this condition later on. Illusions as well, isolation. So this is for more on the schizoid personality disorder. Marked impairment in functioning, lack of initiative, interest, or energy. Okay. Now looking at this is basically a figure or a picture that gives us a visual presentation on how the course of schizophrenia takes place. So before the premorbid or in the premorbid phase, so there are mild motor, cognitive and social impairments. So mild meaning to say these are okay. We can still work with them. They are still showing good functioning. However, in the prodromal phase that was mentioned earlier, they are already showing unusual psychotic-like symptoms. But in terms of normality, they are still considered normal. But here it's going down already. So, and usually it starts around the age of 20. The onset or the deterioration phase, this is where in the positive, negative, um, cognitive and mood symptoms would occur or likely to occur, and usually the severity of the symptoms tend to vary here. So this is from 20s to 35, more or so. And then in the chronic or the residual phase, the positive and negative as well as cognitive symptoms stays, but the severity it's not at all that varied unlike in the onset phase. So what does it mean? It means that the symptoms stays with the client despite of the management and the intervention. So again, this is why the intervention matters, especially if um, there are medications involved. So the person with this condition really have to religiously take their medicine in order to manage the symptom, particularly the positive and the negative symptoms. Okay, now the causes of schizophrenia, biologically, it was seen that families with history of schizophrenia inherit a tendency for schizophrenia, but not what type of schizophrenia. So if there are history, there can be a possibility, of course. There is an increased risk with genetic relatedness. So having a twin with schizophrenia incurs a greater risk than having an uncle with schizophrenia. So meaning to say, because having twin is actually um, not rare but seldom in our case, right? Meaning to say, if you have a sibling with schizophrenia, you have a higher risk for schizophrenia than someone who has, um, let's say, a cousin or an uncle with schizophrenia. Okay, so as we can see here in this graph, we can see the risk, the potential risk of developing schizophrenia based on your relatedness. So for an identical twin, the percentage is higher, or the risk is higher. For the child of two parents who have schizophrenia, the risk is slightly lower, but only slightly lower than the identical twins. For the fraternal twins, there is a big decrease. For children with just one schizophrenic parent, so the risk is also lower as compared with the first two children. The risk is also lower, siblings quite lower, and as we can see, um, as the genetic relatedness goes or decreases from the affinity, the risk also decreases. Okay, so to answer the question, namamana ba siya? Yes. The response is yes. Namamana siya. Okay, now from the adoption studies, um, an adoptee risk for developing schizophrenia remains high if the adopted child's biological parent has schizophrenia. However, the risk is lower for children raised by their biological parent with schizophrenia, and the healthy environment actually is a protective factor that decreases the chance. Okay. Now this is a picture of the ge- Genian, Janine siblings, or the Janine sisters, um, quadruplets. They are quadruplets actually, and all of them have a schizophrenia. So, although the chances are lower than since they are not monozygotic twins, right? The chances are lower. The problem is that the chance is still there. The probability was still there. So this is why all four of the sister, all four of the sisters have schizophrenia.
Hello? Hello?
Now, for the genetic markers, we are still looking for the genetic markers of what causes schizophrenia to develop. However, what they have seen so far is that the endotypes and the phenotypes are, which are processes that contribute to the development and maintenance of a disease, can give us a potential clue as to what really leads to the development of this condition. Um, so far, the best guess is that schizophrenia occurs because of the involvement of multiple genes. Okay, and then in terms of the behavior, for the behavior marker, what they have seen so far is that schizophrenia patients have shown reduced ability to track a moving object with their eyes. So this is why with children, this developmental milestones are quite important to observe for children, because this can be something that will that can lead to the development of schizophrenia later on, or can be seen as a potential yeah sign that there is a possibility for schizophrenia later on. And then what they have also seen is that the relatives of the patients, although they are not diagnosed with schizophrenia, have also deficits in the area in tracking a moving object with their eyes. Okay, for the neurobiological influences, what they have hypothesized so far is the involvement of the dopamine. So, what they have seen is that people with an overreactive dopamine are the ones who are showing symptoms of schizophrenia, and there is an evidence that backs it up, or in drugs that increase dopamine or the agonists result in schizophrenic-like behavior, and then with the drugs that decrease dopamine or the antagonists reduce the schizophrenic-like behavior. So a good example would be the neuroleptics, L-Dopa for the Parkinson's disease. um, However, this remains a hypothesis despite of the evidence, because deemed to they have deemed the problem to be very simplistic, and they are not really accepting that answer to be that simple, because we know for a fact that neurotransmitters are quite complex. It's not just one neurotransmitter that can be involved, or that is involved in one in one action or behavior, and basically the neuroscientists don't want to take any chances, especially since we have not really yet fully explored the potential of the brain. Another would be the structural and functional abnormalities in the brain, wherein they have seen an enlarged ventricle and reduced tissue volume for people with schizophrenia. Also, they have detected hypofrontality, wherein there are less active frontal lobes for people with schizophrenia, and this frontal lobe actually is a part of the brain that is usually where the dopamine um, courses through. Also, history of viral infections during the early prenatal development can be a potential cause. However, the findings are still inconclusive. So there's not enough evidence to prove that there is a contribution of this infection to the development of schizophrenia later on. Okay, so what we are seeing here is a PET scan for a treatment of schizophrenia. So this is the one without the drug yet. So we can see the active part here. So likely this is where the hallucination is happening. Usually it's just supposed to be the left side. Anyway, so let's say this is where the hallucination is usually happening. However, we can see a big decrease in the activity when the client or the patient is given haloperidol. And haloperidol is one of the known antipsychotic medications. Okay, so this is the brain, and Usually, what they say is that people with schizophrenia tend to have enlarged neural ventricles as compared with people without schizophrenia. So, this one. This one. And again, since the dopamine usually passes through in this area, so this can be um, passed through as well, thus causing the symptoms to happen. Okay, so the other neurobiological influences, so I did say earlier that the drug use or history of drug use can increase the risk for developing schizophrenia, um, particularly marijuana. They have seen that it causes or it triggers more the condition to happen, unlike with other substance. Okay, so basically what we have so far about the neurological studies or neurological hypothesis regarding schizophrenia is that there is a diffusion on um, the neurobiological regulations in the brain, and also there is structural and functional brain abnormalities that happens for people with schizophrenia. However, this is not entirely unique for that particular condition only. There are also other conditions that have structural and functional brain abnormalities. Okay, for the psychological and social influences, there is a big role of stress, as this may activate the underlying vulnerability of the person, and it can also increase the risk of the relapse of a person. So, I remember one anecdote wherein this was told to me by the psychiatrist that I worked with before. He was telling me that he had a client or he had a patient with schizophrenia. Um, he was beginning to be okay because he and his family have been visiting him regularly. So the medication is updated, the therapy is also done religiously. So he was quite functional. However, there was a severe relapse, or he went into a relapse after his mom got remarried. So that was stressful for the patient because of the fact that the new husband of the mother did not understand his condition, and the new husband was not also interacting with him, and then of course the time of his mom, although he's already an adult, the time of his mom had to be divided between him and the new husband, uh, because he was already residing with them. Okay, so so with family reactions, interactions, sorry, there is a possibility, although these are unsupported theories. Um, there are ideas that uh, the schizophrenia might be triggered because of a schizophrenic mother, wherein the mother tends to be cold and dominant. However, again, it has not been backed up by studies. Okay, and then with the type of the double bind communication of parenting style, so this is a type of parenting style that involves mixed messages, wherein you're going to tell your kid like, sure, go ahead to the party, but then be be sure that you're ready for the consequences. So that is mixed messages. Are you allowing me to go to the party, or am I not allowed to go to the party? Because if I go to the party, there will be consequences. So that's a double bind communication. However, again, just like with the earlier one, it has not been really linked to schizophrenia with empirical research. So, and then family interactions with high expressed emotion, like for example, criticism, hostility, or as well as over involvement or intrusiveness, tends to be associated with high relapse rate. And so, just like what happened with the client that I was mentioning earlier. Okay, so cultural differences in express emotion. So we can see here percentage, of families with high emotional expression. So it's higher with Anglo-American, and then it is um, okay. So again, people with higher EE tends to have um, triple. They tend to have a triple rate for relapse compared with individuals living in a family with low express emotion. So you can see that for an Indian family that is usually an extended family, there is low expressed emotion, so therefore the relapse rate is not that high. Okay, so what is the role of the psychological factors in the cause of schizophrenia? So, of course, this will function as a diathesis in the diathesis stress model. Um, and with that being said, this will be only triggered minimally, or it does not really have a big impact in producing the schizophrenia per se. Because as we are seeing so far, there's a big involvement of the genes in this particular disorder. Okay, so medical treatment for schizophrenia, historically, the treatments before were often ineffective and quite barbaric. So we have discussed this in, I think, chapter 1, chapter 2, wherein people who would show signs of schizophrenia would be dunked in cold water. So, so basically the way of treating people with schizophrenia are quite it lacks efficiency, so to speak. It was only later when the neuroleptics are developed when it began to get better. So it was sometime in the 1950s, and with the neuroleptics, it reduces or eliminates the positive symptoms. Um, and it was seen to affect the dopamine system as well as the serotonergic and the glutamate system. Okay, so with the acute and permanent side effects, those were seen to be common with the first generation medication. So sure, it was effective, unlike the previous treatment or management. However, the side effects were quite undesirable. So they have this like Parkinson type side effects. Also, they have what they call the tardive dyskinesia, which is an involuntary movement in the face, mouth. There's also an involuntary protrusion of the tongue. There might be some tics that you would be looking or be noticing with them. But this might be, um, this might be, how do you call it? That will be due to the medication. Yeah, this one, as I've been saying again and again, this is the this is the problem that I usually see with my clients. Compliance with the medication is totally a problem, even up to present. So, a lot of them really doesn't like the side effects, of course. The financial cost, psychopharmacological medications are quite costly. So this is why, in my case, as much as I can, if I can see that the case um, can be can be managed with just psychotherapy, I would be recommending that. But if in the instances that it's not doable, I would recommend the client to look for a more economical doctor or psychiatrist that would help them look for um, affordable medications. And of course, poor relationship with doctors. Um, with some of the cases that I've handled, one of the problems as to why they don't go back to their doctors is because they don't really feel rapport. They don't feel that they have established rapport with them. And which we cannot really blame on the doctors, especially if they are from government hospital. They have a lot of patients, and we all know the situation in the hospitals. Usually, it's a one 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 doctor to 100 patient ratio, so it cannot be really managed to a level wherein the doctor will have uh, longer time spent with the patient. Okay, for the psychological treatment, psychodynamic therapy was of course seen to be not that effective for the treatment of schizophrenia. However, later on um, with the other approaches like the behavior approach, it was seen to be better. Behavioral, um, like token economies for patients inside the hospital, they are rewarded for the adaptive behavior. Like for example, they are eating on time, they are taking their medications well, so they are rewarded for that. Like they are given extra hours to watch the TV. Um, Also, uh, other cultures or societies have a community care program. They also have established social and living skills training, as well as behavior family therapy and vocational rehabilitation. So, in the National Center of Mental Health, or the NCMH, the patients who are better, or who had been in relapse but are still functioning, they would have them, or they would teach them to make soap, and they would sell the soap outside of the facility for additional funds for the hospital. Okay. For the illness management and recovery, so this is actually a good way to engage a patient as an active participant in the care. And usually to do that, you have to make the goal setting and tracking continuous. So this one would include social skills training, stress management, as well as substance use. So you're going to teach them what the substances can do to them, and of course the consequences of using these substances again. So, in this one, cultural considerations, we have to take into account cultural factors that influence individuals' understanding of their own illnesses. So, like for example, there's supernatural beliefs. If they have this, let's say their delusion of grandeur is that they are the voice of God, so you have to take that into consideration. Also, um, the relapse is actually lower, and not only for schizophrenia, for other conditions as well. And the treatment, the treatment efficacy is higher if um, the treatment would involve both the family and the community. So in prevention of schizophrenia, we have, of course, to identify children at risk. So these are usually children with relatives who has schizophrenia. And of course, there should be a supportive and stable environment if they are identified to be at risk. Um, Another would be to offer additional treatment during the prodromal stages, including the social skills training. So, this in that way, even though the symptoms would later on unfold, the person will still be able to manage some of their behaviors better, or still function in some aspects better. Okay. Now, let's see this figure or this graph wherein we're looking at the different treatment of schizophrenia. So the first one, okay, and then this one, the y-axis shows us the percentage with major relapse after 2 years. So this one is the psychosocial intervention with drugs, and then combined with with support or education. And then this one, as we can see with that, the first intervention, the relapse is at 65%. We're in the second type of intervention, drugs plus or the medication per se. Plus social skills training, the relapse is quite lower at let's say 35 or 38% here. And then if it's a combination of medication plus family stress management, it's also lower but higher than the second one. But it's below 40%. So I think it's about 39%. Okay, so to sum it all up, the psychotic disorders are group of disorders that shows us a break from reality, resulting to a spectrum of dysfunctions. And this spectrum of dysfunctions affects the cognitive, emotional, as well as the behavioral domains. And then with schizophrenia, it involves the positive, the negative, as well as the disorganized symptom cluster. Okay. As for medication, medication is somewhat effective for the positive symptoms. However, there is need for, of course, improvement in the treatment. So that's it